Well, hello and welcome. I'm Ann Belegia. I'm one of the 1,700 members of the Osher Lifelong Learning Institute at Southern Oregon University, also known as OLLI. And on behalf of OLLI, thank you for joining us for this first program in the Cardiovascular Health in You lecture series. And we certainly hope you'll join us for the next three programs in this series. We're very grateful to Asante for their longstanding support of these free public community health programs, and this is the fifth series for which they've been providing speakers and topics. Now, we'd like you to put your questions into the chat, and that's going to be moderated by Dr. Stephen Hirsch. And I have the honor of introducing Dr. Hirsch. He is a longstanding physician in the Rogue Valley. He has served as a hospitalist, and he's most recently been the Director of Medical Affairs for Asante Ashland Community Hospital and Asante's Medical Director of Quality and Patient Safety. And Dr. Hirsch has been instrumental in facilitating the arrangements for these lectures. And welcome, Dr. Hirsch, and please introduce tonight's speaker.
Thank you, Ann. It is my honor to introduce Dr. Brian Gross. Dr. Gross originally hails from New Jersey. He has his undergraduate degree from Wesleyan University and his medical degree from the University of Rochester. He then served his internship and residency at Dartmouth and then moved to the state of Washington, where he held a fellowship and an assistant professorship. Dr. Gross eventually migrated down to our portion of Oregon, and we are all the more fortunate for that. Dr. Gross was the local investigator for the Gusto trials, which were huge worldwide trials and very pivotal. He's a fellow of the American College of Cardiology and on the Council of Clinical Cardiology of the American Heart Association. Importantly, Dr. Gross headed up the ASSET trial, a trial done locally demonstrating the important role of shortening the time but for a patient to get to the cath lab and get their arteries opened. Again, another important and pivotal trial. Dr. Gross is married. He has 4 children who love to raft, play soccer, play basketball. He takes these amazing pictures of his family in these remote, wonderful locations. If you ever get a chance to see them, they're wonderful. I am privileged to call Dr. Gross a friend and a trusted colleague, and I'm thrilled to introduce him to you, and can't wait to see what he has to teach to us today.
Very good. All right. Well, thank you. Thank everyone for coming. I hope I'm going to be able to educate you, even entertain you a little bit, and give you a little bit of encouragement about what has happened in the field of cardiology these last few decades. It has been an amazing journey. Still have a ways to go, but we've had some phenomenal success. And what I'm going to focus on tonight primarily are the fuel lines of the heart, the coronary arteries, but we'll also talk about some arrhythmias, lots of other stuff in terms of lifestyle adjustments and heart muscle function and valves. Well, those are in surgery. That's for the upcoming talks. I hope you'll join us for that as well. But we'll be talking primarily about these arteries, and we'll also be talking about the heart rhythms. Just my one disclosure is I'm the co-director of the State of Jefferson STEMI program, and I'll tell you a lot more about that in just a little bit. But the heart's an interesting organ. 100,000 heartbeats occur in every one of us, and it gets distributed through 60,000 miles of blood vessels. If you took every one of those blood vessels and put them end to end, you could have a hollow tube that you could wrap around planet Earth 2.5 times. That's a lot of plumbing. So we're going to concentrate on the fuel lines primarily, as well as some electrical arrhythmias. And we're going to leave the valves and the heart muscle function and the surgical things to another night. So when we look at the arteries, they all have various names and locations. This is what you learn about in med school, and then even more so in cardiology fellowships. and this latex filling of the arteries and then dissolution of the meat around it shows the incredible complexity. And this is just the major vessels. This is not the tiny small capillaries, which are very important for delivering blood. And we can look at these arteries through angiograms, and we can look at them through CT scans through various techniques. What I've used this slide a lot of times. This is a fascinating thing. I think modern medicine started primarily with President Eisenhower's heart attack. There were no treatments for most heart conditions. There were antibiotics, but there was virtually nothing else available in the 1950s. In the third year of his presidency, while out in Colorado playing golf, in the afternoon, he developed a disagreeable heartburn-like sensation that got worse in the middle of the night. They called in the physician from the Fitzsimmons Medical Center, and he didn't think it was anything but heartburn. The following day, they brought back an EKG machine as big as a desktop table, and whoa, they were surprised. It was a heart attack. There were no treatments at that time. And when he became incapacitated to a certain extent, lots of things happened. We had basically just oxygen tents. We could give him amyl nitrite, which is the equivalent of a nitroglycerin tablet, or we gave him morphine. Well, the morphine doesn't do anything to make the heart attack go away or minimize it. It just basically takes care of the pain, and the heart attack will run its course. The stock market took the biggest tank it had ever taken since 1929. I mean, here was the man who saved the free world, and then suddenly he's incapacitated, and the world panicked. They brought out Dr. Paul Dudley White from Harvard, and because they felt that they needed to get a civilian physician to weigh in on it, and he saw him, and it was a 6-week hospitalization for his heart attack. We have the average heart attack now is 2 to 3 days in the hospital, and they're up and getting around. He was golfing 5 months later. They said, oh my gosh, golf probably brought this on, all that activity. And nowadays, we get people up and about and we get them moving. We don't let them lie there and become deconditioned. He had a stroke 2 years later from which he recovered. He had 7 more heart attacks over the next decade, 14 cardiac arrests where his heart stopped. He was instrumental in some of the development of the very earliest defibrillator. There's a whole nother story. We had the first defibrillator here in Medford, west of the Mississippi. That's a whole other story. I'll tell you some other time. He was treated with new medications that came out. He spent the last 9 months of his life in Walter Reed Hospital in congestive heart failure. We had no treatments for congestive failure. And then more doctors smoked Camels than any other cigarettes. That was he smoked 4 packs of cigarettes a day until he quit after his heart attack. I basically have coined this term that the president who warned us after World War II of the military industrial complex, I believe was responsible, sowed the seeds for the medical industrial complex. So there are these arteries, and this is what a healthy right coronary artery would look like on an angiogram. Here's an artery that has a very mild plaque that narrows the path. Here's one that's 95, 99% blocked, but still blood is getting through. And this is a STEMI, an ST segment elevation myocardial infarction, where this blockage has continued to develop clot and it completely blocked the flow. And when that happens, that's the equivalent of you having a blood pressure cuff put up on your arm, and the nurse walks away and forgets to take the blood pressure cuff down. After about 2 or 3 minutes, you become an unhappy camper. And if you don't get that artery open, you don't let that blood pressure down, you're going to lose your arm in about 12 hours. So I like to use a lot of analogies with plumbing, because what we do in the cath lab and what we do in our offices to treat these arteries, it's basically high-tech plumbing. Normal plumbing would be wide open. Here's a person who's got a pretty nasty bit of blockage, but there's still plenty of room for the water or the sewage to flow through there. And when it's mild and moderate like that, drugs like Drano do a pretty good job of reestablishing at least adequate flow. But pretty soon you start building up a really serious blockage, and you know, stuff starts backing up in the sink, doesn't drain very well. You begin to get a little bit worried about it, and disaster occurs when you really block it off completely. And this is how many people are going to feel when they're in the middle of a heart attack. So when you get these more serious things, you need to have mechanical interventions like plungers, like rotor-rooters, and we have medical equivalents of all that. And ultimately, you might even need bypass surgery, new plumbing. So the main thing that happens is the buildup of plaque, slowly and progressively until suddenly it gets worse with a blood clot. But there are other causes that can block arteries that are relatively rare, but we see them periodically, and we always have to remain aware of them because they are treated differently than a plaque rupture with blood clot occlusion of the vessel. The vessel can split. The vessel can bleed into the wall and narrow it. The vessel can spasm, or a blood clot can come from somewhere else in the heart and clog the artery. And in addition, you can also get microvascular disease, the tiny little blood vessels that we know are there that we can't see and visualize, but they can wind up constricting. And all of them can give you chest discomfort. So how do we diagnose this? The first thing is we start with a diagnosis. It starts with taking a history and then a good physical exam. And then we decide on appropriate testing depending on what their symptoms are, whether it's chest pain or shortness of breath or palpitations or dizziness. And we may get an electrocardiogram, we may draw some blood tests, may get a chest x-ray, and often we'll be getting a treadmill or a more sophisticated treadmill called a cardiolite study where we can actually image the heart while we're exercising it. We may do a CT scan looking at the major arteries. It doesn't show you the detail of the smaller vessels. We may do an echocardiogram. They're very frequent. We may put a monitor on to measure their heart rhythms, or we may take them to the cath lab just to make a diagnostic angiogram or to actually open up an artery should a blocked artery be the source of the problem. So we have non-invasive strategies for treating it. If you get somebody who smokes a lot, doesn't move around a lot, eats all these terrible foods for you, as opposed to somebody who does things right, if you're selling insurance, you'd much rather be insuring her than him, because this person's going to run into a lot of medical bills. No smoking being one of the most important things that people can do. And we have medications, many different kinds of medications to treat blocked arteries, starting with something as simple as aspirin, and then other drugs like Plavix and beta blockers and all sorts of long-acting nitroglycerins and cholesterol strategies. All of that's going to be talked about in greater detail in one of the other conferences. And then we also simultaneously have to treat their blood pressure issues, their diabetic therapies, and these new drugs that are sweeping the market that help with the overweight diabetic patients. And then in more emergent situations where people aren't responding to medications or have very dramatic EKG changes, we use more potent drugs and take them right to the cath lab. So if you ever need a heart catheterization, we have many ways to get there. Traditionally, for decades, we'd always go in the big artery in the groin and back up the aorta to the heart. And nowadays, we do many of them through the smaller artery right in the wrist. And we have all sorts of different catheters that help us find that artery. You're basically putting this tiny little tube from far away and have to get it into the tiny little hole, 2 to 3 millimeters in diameter, through which the blood flows down the heart. And here's what a normal heart artery would look like. And here's a person with a severe blockage. And if you had a blockage like that, we would float a wire across there and then measure the artery diameter, measure the length, pick out a stent that is mounted on a balloon catheter, put it across, make sure we got it in the right spot, blow up the balloon, deploy the stent, and then pull the deflated balloon and wire out. And the artery is then wide open. So this is what these stents look like. They come in all different sizes and shapes. They're high-tech cut. You can see these little designs here. They're designed so that when they're crimped really tight on a balloon stent, they can be expanded without shortening. And these have to be accurate to within a millimeter of their length in terms of the size you're picking and the diameter. They're anywhere from 2 millimeters in diameter all the way up to 4.5 millimeters, depending on how big the artery is that you're stenting. Here's an interesting fact. There's these we first only had balloon angioplasty, and every time you did just a plain balloon inflation of the artery, 40 out of 100 of them would come back because there was nothing to hold it open. And then we got a bare metal stent in 1995, and out of every 100 you did, only 15 would come back. And good is good, but better is better. And benchtop research found, you know what? There's two substances that you can coat these stents with that will dramatically minimize the chance of a recurrence at that spot. One was Taxol, which comes from the Pacific Northwest yew tree, and we used it to treat ovarian cancer for many years. And then it got put on the shelf and it wasn't used until somebody found you could coat it on these metal stents and it would delay and prevent the restenosis. But the other one that we use more commonly comes from one place in the world. It comes from the dirt on Easter Island that they have modified in the cath labs, in the research labs. And it's fascinating stuff. They used to use it to prevent kidney transplant rejection. They got better drugs now. It went on the shelf and then someone resurrected it and found that if you coated the stents with that, rather than 40 out of 100 or 15 out of 100, only 3 out of 100 come back at the spot you stent. It doesn't cure your heart disease, but it sure controls it. And they even have dissolving stents that are trying to make it into the market. They're made of a high-tech glucose kind of substance that will gradually dissolve. So think of a blockage in an artery like a kink in a garden hose, very little flow going down it. And what you do is you put that across and you blow up the balloon and you put the stent in there. Here's an example, and there it is when it's done. You can't even see the stent. They're paper thin, but they're very, very strong and scaffold open the artery. Now, sometimes things are more difficult. Here you got a moderately tight blockage, but look at here. You got two branches. If you put a stent out this one, what's going to happen to that plaque? It's going to push it over into this one. Oh, but what happens if you put the stent there? It's going to push it over there. We got ways to deal with that. We put 2 wires down. We put 2 stents down, and we blow up both. And so we call that a bifurcating stent or a pantsuit stent. We have ways of looking at the inside of the artery either ahead of time or after we put a stent in to make sure that the repair that we have done has really done a good job. And here's an example of what this looks like. It's a virtual reality of the inside of the artery after we put a stent in. Here's the wire. We're way down here, and we're going to drag this thing back, and we're going to look at the stent all along this area. And if we see an area that's red, we know, like out here, we have to put a bigger balloon and expand it and crush that stent. There's a side branch right there in the end. And here's the beginning of the stent up here. And now we're back in the original artery. It really helps you understand what's going on. This is all happening in a vessel 2.5 to 3 millimeters in diameter. Sometimes we have people who have blockages in their arteries that are very, very sick. They have very low blood pressure. They are trying to die. And we need to enhance their heart while we get that artery open. We need to help it beat. And we have these big, long sausage-shaped balloons that we can put out in the aorta so that when the heart squeezes, the balloon is relaxed. And as soon as the heart stops squeezing, the balloon expands and sends blood in all directions, taking over part of the work of the heart. They have improved that with this pigtail catheter that we put in these hearts and can leave in for a couple days at a time. And it literally sucks the blood out of the main pumping chamber, the left ventricle, puts it through this tube, and then squirts it out under pressure into the aorta. And it's an auxiliary heart. It's kind of like a mini bypass. There are problems with this, but if you're dying and you don't have much blood pressure, these are things which can be life-saving. It's very similar to the impeller motors that you see on those jet boats that go roaring up and down the Grants Pass, or you see elsewhere on the road. It's the same principle. Sucks it in here and blows it out there. And the other thing that we can do is obviously bypass surgery, and Dr. Jacks will be talking about that, I believe, at the next session. So let's talk about STEMI, which is kind of a place where Southern Oregon, Northern California has had its biggest inroads. We actually had the very first STEMI system probably in the country, maybe the world. What a STEMI is an ST segment elevation myocardial infarction. It is a complete blockage of the entire artery, cutting off the blood supply, and all sorts of alarms go off in your body with chest discomfort, shortness of breath, anxiety, sense of impending doom under most circumstances. And you got to get that artery open quickly, because the longer it remains closed, the more muscle is going to die. So here's a person with a normal artery. Now this person here, this might have a partially blocked artery that's full of blood clot like this, but there's still plenty of lumen for blood to go down, even though there's blockage and ruptured plaque. But what a STEMI is complete blockage. In the attempt to heal this crack in the plaque, there was a crack there, and then it cracks, and the body tries to heal it with a little bit of blood clot. It makes too much blood clot. It fills it, and now it blocks it off. So the artery is completely blocked, and you have to emergently get the stent in there and get it open. Here's an example of what would happen. And you have blocked arteries like this. We all do, probably even in our teenage years, we might have a little bit of plaque that is not giving us any trouble. Over time, all of a sudden, it cracks, the body tries to repair it, and now it closes it off. And if you don't get that open quickly, all this muscle may die. The V8 engine becomes a V5. Here's an example what happens. These were done with dog labs where they blocked off an artery with a ribbon and then released a ligature and then released it after 2 hours, after 4 hours, and after 6 hours. And you can see the longer it remained blocked, the worse the prognosis was, the more heart muscle was lost. So there's this saying that we have time is muscle. We use the same principle. They've copied us in the world of the cerebral vascular disease. Time is also brain when you have a stroke. So here's the history of bypass, of STEMI, ST elevation myocardial infarction. 1950s with Eisenhower, 60s and 70s, there were 0 treatments, 0. And 1 out of every 4 patients who went into the hospital with a heart attack, a STEMI, died, never left. In the 1980s, we began to have coronary care units. We had a few medicines to treat congestive failure. We had bedside nurses that if you went into a fatal heart rhythm that first day or two could shock you, and the death rates dropped to 15%. In the 1990s, we were part of the world's largest study in looking at blood clot dissolving medicines called TPA or thrombolytic therapy. And we proved that you could lower the death rate from 15% to about 10% if you gave these drugs. But the good is good and better is better. And those of us who were doing stents found, gosh, if occasionally we took a patient with a heart attack directly from the emergency room to the cath lab, we could get that artery open 98 times out of 100. And wow, the patients felt better immediately and without a lot of bleeding. So we started doing this in 2003. We published a couple articles, and we'll get to that in a bit. But the blood clot dissolving medicine is known as a door to needle time, and we still do that in places in Eastern Oregon or over on the coast where you can't possibly get to our cath lab fast enough. And it's an effective strategy. It's just my favorite blood clot dissolving medicine is a piece of stainless steel or cobalt chromium, which you put in there and it opens up that artery very quickly and more completely. Here is an example of the very first blood clot dissolving medicine that was done in Oregon. This was me fresh out of training at the University of Washington. And I came down here and I had this young man, one of the first weeks I was here, and he had closed off his right coronary artery right about there on this drawing with a blood clot that if you looked on an electron micrograph would look like that. He was low on his blood pressure. He had a very slow heart rate. I had to put a temporary pacer in. And back then, we weren't giving these blood clot dissolving medicines intravenously. We had to put a catheter in the heart and trickle the blood down. I'd have a big syringe and I'd give him a short little burst of medicine to try and dissolve this blood clot. And after about 15, 30 minutes, I'd inject some dye down there and it would not go anywhere. And after about a half an hour or 40 minutes, I dissect it and holy mackerel, I got it open. But that's a pretty unstable residual. But this was a roaring success in 1982 because we had reestablished blood flow, and his pain went away and his heart rate picked up. But nowadays, we have a much more effective way of doing it. Just take them emergently. Here's a complete blockage of the artery on the front of the heart, right there. All that's going to die. If you don't get it open, you poke a little wire across. You put one of these little stents in there. Here it is being deployed over the wire. The catheter has the balloon. You blow up the balloon. The stent gets deployed to that. And there it is now wide open. So we have a weekly cath conference every Wednesday morning. Had it this morning, where we talk about challenging and interesting cases and didactic issues. And we were getting very frustrated that we would have patients that would come from Josephine County or Northern California or Ashland or anywhere. And it just took forever to get them to the hospital to get the thrombolytic therapy. And we decided we were going to try this unproven, but which made total sense to us, of taking everybody within 60 miles as soon as they wound up having a heart attack confirmed by the EKG, we would rapidly transport them by ambulance to the pre-alerted cath lab and open the artery just as quickly as we could with a stent. And so we have the mothership right here, which is Asante Rogue Regional Medical Center, which has open heart surgery and multiple cath labs and 20 cardiologists. And we have these way out on the coast, Gold Beach Hospital and Sutter Coast Hospital, and the 24-hour Brookings. These are small critical access hospitals, just like 25 beds. They don't have cardiologists. They don't have cath labs. We've got Ashland, which is a small hospital. We have Three Rivers, which doesn't do balloon. They've got a single cath lab, but only 2 cardiologists up there. They don't do stents. Providence was doing stents for a while, but they don't have enough staff. So basically all STEMIs that walk into their ER are sent immediately to us. We have Fairchild Medical Center, Mount Shasta, and Lake District Hospital. And Klamath Falls has copied our model. They have 4 good cardiologists over there. They will do all their emergent stents, but if somebody needs surgery, they will bring them on over to us. And then occasionally we'll get somebody from Roseburg. So here's the data. Every hospital for decades has been monitored on what their mortality is for a major STEMI heart attack. And for many years in the 1990s and early 2000s, Rogue Valley Medical Center was considered a top 100 hospital because our death rates, utilizing mostly thrombolytic therapy, was 8.6%, while all the other hospitals averaged were about 11.8%. We were, well, it was a 4 percentage points higher salvage rate. We started our program in June of 2003, where we took every patient, rather than giving them a blood clot dissolving medicine, we'd bring them directly to the cath lab to open them up. Unbelievable drop. 233 consecutive patients, only 2.1% patients passed away. If you walked into another referring hospital first and had to be referred down, the overall mortality was twice what our overall was, but half of what it was when we were a best hospital in the country. And here was the interesting thing. If you walked into Rogue Valley, you could get immediately into the cath lab. Time is muscle. The longer you spend traveling or hanging out in the emergency room, the lower the survival. 0 died. But the really critical feature was, if you called 911, even as far as 60 miles away, we taught the paramedics how to read the EKGs, and they would bring them directly to the pre-alerted cath lab. 0 out of 81 patients out of those first 233 died. This was astounding. I presented it one day. I was at a major meeting with Doug Weaver, who was head of the American College of Cardiology, and he was a big blood clot dissolving man. He said, "Oh my God." He said, "You got to publish this." I said, "I hadn't published an article in 25 years. He said, "I will help you publish this. This needs to get out." So we published this in 2007. The rest of the country said, maybe, perhaps, okay. We had proposed a heretical approach to treating a heart attack. Paramedics would diagnose in the field, bypass the closest hospital, and go directly to the pre-alerted cath lab. Back then, all chest pain went to the closest hospital. This was a major change in the way we treated heart attacks. Fortunately, from our standpoint, it worked out well. And now the rest of the country uses the same model. primary percutaneous intervention, putting a stent in an artery, is the most complex, multidisciplinary, and time-sensitive therapeutic intervention in the world of medicine today. The key word here is time-sensitive. We have to move extremely quickly. You'll see some things that Dr. Dowderman will do with incredible stuff where they're stenting in valves instead of doing open heart surgery, but it's not time sensitive. They think these things out. They've got everything prepared, ready to go. Backup people talk about the cases. These come in the middle of the night, and you're having to open them. The process is literally measured in minutes. The outcomes are measured in mortality. Teamwork and smooth transitions are absolutely mandatory. Ivan's a good friend of mine. We've published a couple of heart attack articles. So here's kind of what's going on. You've got a patient who's coming down through the ER. He's got chest pain. It's hard to get a history. The spouse is hard to get a history from because they're worried. We're taking them to the cath lab. These are all the different things we're having to consider with that patient who is potentially unstable with blood pressure or heart rate and their heart rhythms. And what medicines am I going to, what are they allergic to? What are their other medical problems? And oh yeah, in the last couple of years, we've had to deal with the issue of COVID, and you know how backed up ERs can be. So now I'm going to share with you what I think is the most incredible save in the entire world. Dr. Dowderman did this one. Beautiful Crater Lake. It's a long way from here to there and back if you were going to go by ambulance. A 51-year-old woman from Vancouver, Washington, was with her Boy Scout son and the Boy Scout troop camped over here at Diamond Lake. And they decided that day they were going to bicycle around Crater Lake. Beautiful, can be done. And about a couple miles into the race, her best friend, who was a scoutmaster and also the SAGWAG driver, took one look at her as she was pedaling up a hill, and she was pasty yellow, short of breath, looking awful. She threw the bike away, threw her best friend in the car, and headed for the most remote portion of all of Oregon, the north entrance to Crater Lake, farther from healthcare than you can be, just about anywhere in the state, where some 18-year-old college kid taking fees to get into the national park took one look, doesn't know anything about medicine, but knew this person was sick, and called the park ranger paramedic. Guess where he is? He's over here where all of the tourists are, at the lodge. He jumps in his rig and starts driving on down here to get to her. He gets to about here, and the kid calls back, said, she's really looking bad. He calls Mercy Flights, who launches a helicopter. That almost never happens without a paramedic laying eyes on a patient. They start coming. He comes continuing driving, and about 5 minutes before he gets into the parking lot, she goes into a full cardiac arrest. And her son and the Boy Scout troop leaders, they're all doing CPR. This is obviously not them, but they're doing CPR. The park ranger comes skidding into the parking lot. 5 minutes later, pulls out his AED, and it shocks her 3 times. And finally, it says no further shocks necessary. They had reestablished the heart rhythm. About 10, 15 minutes later, the helicopter lands, and they get the EKG. And this is a nasty looking EKG. It's got STEM acute MI. It's got fast heart rhythms. It's got these big ST elevations. They load her up, start a bunch of IVs. She's got virtually no blood pressure, and she has to be shocked several more times in the helicopter. They radioed ahead. Dr. Dowderman met him at the helicopter landing, race her into the cath lab, and here she is. Here's the blockage, complete blockage in the most important artery that normally would go all the way down here, called the LAD, left anterior descending. We affectionately call it the widowmaker, or in this case, the widower maker. It's the most important artery, completely blocked. What he does is he pokes a little wire, no bigger than a hair, steers it across through the blood clot, down in the vessel, and reestablishes flow. And now he's got a little hollow tube, and he's literally sucking out any free blood clot. This is what he gets out of it. And then he's going to deploy the stent. These little markers, he knows what the diameter, he knows what the length is, and he deploys that stent, and then he deflates the balloon and pulls the wire out. and a wide open artery. Now, the patient's blood pressure is now up to 70 millimeters of mercury. She's unconscious, she's intubated, and we're not sure she's going to survive. She's had a total of 12 cardiac arrests. 12 times she's tried to die. She's on massive doses of medicine to raise her blood pressure. Take her up to the coronary care unit, and we chill her down just like you chill an ankle that is swollen. And we wait about 36 hours. We start to warm her up. We're hanging a lot of crepe. We're not sure she's going to make it. And she wakes up like this. So here's a woman, mom, teacher, out of hospital cardiac arrest, STEMI, helicopter, emergent stenting. We thought the American Heart Association would like to know about this because it had every phase of the chain of survival. So there she is, and the entire team of people who took care of her. If any one part of that hadn't worked, she would not have survived. She came back a month after this occurred, walked the golf course, and then we had a dinner in celebration for her. So we'll move on quickly with the time that's left and talk briefly about arrhythmias. The very first EKG looks like that. Now we do them, most of them look like this, and I can even do it like this with your iPad. And so the electrical system has a bunch of wires. The major wires look like this. The electrical impulse actually starts there, and it goes to a little resistor here before it goes down to the main pumping chambers. And it's got all sorts of different things that scared the bejesus out of me when I was in medical school. I said, how am I ever going to learn the significance of these squiggly lines and how they impact the heart? And basically, when you look at an EKG, is it rate too fast? Is it too slow? Or is it just right? And then you want to determine, is it coming from above the ventricles or below the ventricles? So this is actually a case of a patient. I have this little thing that I carry on my iPhone, and I can get an EKG. I got a call from a friend of mine whose wife was hiking in Bhutan on a Sunday morning at 7 o'clock when I was here at the office, and she was in great distress at 16,000 feet. And I was able to read her rhythm. They sent a helicopter halfway around the world, and we were able to make a diagnosis. You can have a 6-lead one if you put it on your knee. There's also these little Zio patches are new machines that can measure for 14 days. It'll record every last one of your 100,000 heartbeats. We get 1.4 million heartbeats, and we look for ones that come from the top. We look for the heart if it stops, and it tells you second by second what the heart rate is. And then we have issues where your iWatches can actually measure an EKG to a certain extent. So here's some examples of too fast and dangerous. Here's some examples of too slow that need to be sped up. And then here's an example of something that's just the right heart rate. These are below in the ventricles. These are above. Here's the ones below. They can usually be more aggravating, potentially more serious. These ones at the top can be serious, but they tend to be more aggravating. And these are all of the different types of upper chamber short-circuiting heart rhythms that we deal with, that we have to make the diagnosis, and different treatments are required for each of these different rhythms. And these are the ones from the bottom of the heart, and these are more monotonous, but these are life-threatening and dangerous. So I'll skip the conduction here. That's just more sophisticated EKG. And these are pacemakers. When you have a very slow heart rate, you can put a pacemaker in for 1 lead, 2 leads, and even now 3 leads. And then, of course, we have ones that are defibrillators. So the pacemaker technology has really advanced, and now they have them without leads. They just little look like little bullets we can put in there at various parts, and they can take over the pacing. A lot of you probably have atrial fibrillation, and we deal with atrial fibrillation with various medications to slow the heart rate or to convert it, but sometimes it just keeps coming back. And what we have to do is put a series of burns right where these pulmonary veins bring oxygenated blood back into the heart. There's 4 of them, and we can either burn it or freeze it with a liquid nitrogen in a balloon, a very soft balloon. We're just trying to create a freezer burn or a thermal burn circumferentially, because the atrial fib starts in these pulmonary veins and then short circuits the heart. And sometimes clots form in this little thing like an appendix. So if its only useful purpose or unuseful purpose is to develop clots. And if they break off, they can give you a stroke. So we have this device, little basket, a little cork that we can put up here, poke through from one chamber of the heart to another, and make a cork and prevent the clots from getting out. This is an example of what a fatal heart rhythm would look. This was a patient of mine who I was interviewing one day here in the office, and he suddenly dropped dead, and I quickly got the AED and I shocked him, and he woke right up, and we took him across the street and opened up his valve. I'll skip this one. When people have a really dangerous heart rhythm that causes them to pass out cold, you literally have 10 minutes, and the longer you wait, the less the chance that they're going to have neurologic recovery. The earlier you can get them, the better. That's why these implantable defibrillators in the appropriate people, it shocks them right here where they have a very high survival rate. If it takes 15 minutes or 10 minutes for the paramedics to get there, there's very little chance they're going to survive. Where do you think the safest place in the world is to have a cardiac arrest where your heart would stop? Well, I'll tell you, it's in a casino. Not in the cath lab, not in the CCU. These are relatively healthy people, and they suddenly go into a fatal heart rhythm. They collapse. You have these people watching. The guards and the supervisors who are running security know how to shock, and they know how to do CPR, and they can get it done within 2.5 minutes. And in that is the highest survival rate is achieved by people with that. Those of you driving into Ashland, just after you go under the bridge, you may see this thing called Pulse Point. I brought this Pulse Point to the valley where we are able to, when someone has a cardiac arrest and passes out, and you call 911, they call the closest EMS, but it also identifies any healthcare provider who says they're willing to supply help on a moment's notice, and it activates their cell phone with an obnoxious tone and shows them where they are, where the closest AED is, and where the patient is. And it's called Pulse Point. If any of you are healthcare providers and you know CPR and you want to help, you can download this Pulse Point app for free and sign on, and it would call you if you wanted to help. Just finishing up now with 2 or 3 last slides. Medicine, and especially cardiology and oncology, are rates of medical knowledge doubling is astronomical. In the 1950, I was born in 49, it took 50 years for the amount of medical knowledge to double. In 1980, every 7 years, the amount of medical knowledge doubled. 2010, 3.5 years. In 2020, it was 73 days. It's probably close to 35 days now. How do you keep up with that? Obviously, we need digital technology. There's a limit to how much you can read and assimilate yourself. It becomes more a matter of how quickly, if you have the background, can you access the dose and the type of therapy that needs to be done as quickly as possible. I would just like to finish with some reassurance in terms of people living in Southern Oregon and Northern California. We have access to some of the most successful cardiac and medical care around. There's 324 healthcare systems. For 10 years in a row, Asante was voted a top 15 healthcare system. There's only one other place in the country that has that record, little place in Minnesota you never heard of, called the Mayo Clinic. During that same period of time, 9 years in a row, Asante Rogue Regional was voted a top 100 hospital for all general medical care, surgical care. We have the American College of Cardiology gives our heart attack program these high awards. The mission of the American Heart Association also does it for our heart attack programs. Our open heart surgical programs basically have top 5% for all aspects of open heart surgical care, for aortic valve replacement, both TAVRs and surgery, and heart bypass surgery. Top 5% for mortality. the Centers for Medicare and Health, which evaluate every hospital in the country, with the 3 Asante hospitals, Rogue Regional, Ashland, and Three Rivers. Most years, we are the 5-star for at least 2 of them, and usually for 3 of them. There's 60 hospitals in Oregon, and only 5 of them achieve the 5-star rating, and 3 of them are right here in your local activity. And this is the one I'm most proud of. There are 951 out of the 6,000 hospitals in the country that are considered to be really top-notch, major. When you're super sick, this is where you want to be. We were voted 2020, 2021, 2022, and all these previous years, a top 50 cardiovascular hospital among all the top 951 hospitals in the country for our cardiovascular care. With that, I will finish with our new towers and older towers and the Smullen Center, and open it up for Steve and Ann to field some questions.
Thanks, Brian. We'll give people a couple of minutes to put questions in the chat. I do have one question from one person just asking specifically about the fibers of Purkinje. It's a little bit of a real specific question, but let's take a moment and answer that.
Okay, well, let me take you back to, let's see, I'd have to take you way back here.
There's Brian's family that I was talking about.
Yeah. All right, here. This one, let's see if this shows up. Are you able to see at least some of that there?
Yes.
Okay, so the electrical impulse starts here. It normally beats about 70 beats per minute, but if suddenly you hear gunshots outside your room, and your brain senses a threat and immediately sends a signal, beat faster. When you go to sleep, it says you don't need to beat 70 beats per minute, go 50. And it goes through these wires and then it slows down, and then it goes down these major cables, the right bundle and the left bundle, and then off into these Purkinje fibers, which are basically the the next level of smaller electrical wiring, which delivers blood to the muscle, delivers electrical impulses to the muscle to help it contract. So those are the Purkinjes.
Brian, you talked about the chain of survival, and you mentioned a little bit about CPR and a little bit about AEDs. And to me, that's very important because it's what these folks in the audience here can do if somebody next to them is sustaining chest pain or passes out. I wonder if you could talk a little bit more about the role of CPR and what an AED is and the role of that in this chain of survival.
You bet. So the most common way that people die is, heart attacks. And heart attacks take 2 different forms. There's the plumbing heart attacks that I first was talking about with the clogged arteries. And then there are the electrical heart attacks, which are the cardiac arrests, where the heart is beating along normally, top, bottom, top, bottom, top, bottom, and all of a sudden the bottom quivers and it doesn't pump. And within 5 to 10 seconds, you'll pass out, you'll be unconscious. And if you don't reestablish blood flow to the brain quickly, then basically the end of life arrives. So what the first thing you do is make sure the patient doesn't fall over and break a neck or a hip or something. And then if you can't feel a pulse and they're not breathing normally, you get somebody to call 911 and then start CPR. CPR will buy you an extra 5 or 10 minutes of time. Okay. And if you have an AED, and that's where this pulse point comes in, we mapped with the paramedic assistants every AED in the valley. We discovered there were 2,000 of them, but nobody knew where they were. So we mapped them. So when that alarm goes off and you look at your iPhone, it'll show you where they are. And every time I go into a restaurant or a hotel, I go up to the front desk and I ask the receptionist, "Where's your AED?" And if they respond to me, "What's that?" I say, "Wrong answer. Where's your manager?" The AED is an automatic external defibrillator, is a smart little device, which is a defibrillator machine, which has been programmed to recognize a fatal heart rhythm. And it will only shock a fatal heart rhythm that it can successfully shock. It will not shock you. And it's, you know, it seems complex to put on, but it's 3 simple steps. It talks to you, it shows you with a picture. You just put these 2 pads on and turn it on and stand back, and it takes it from there. And if you can reestablish a heart rhythm, a normal heart rhythm, before the paramedics get there, chances of survival are dramatically increased.
So folks learn how to use an AED in a CPR course. You can get those at the Y, you can get those through the Red Cross, they're in the community. When I see patients who have heart disease or who have had heart disease, and they talk about what to do about it and how to deal with it, besides talking about all the medicines, I encourage their family members, their spouse, to take a CPR course. That's how you learn to recognize these symptoms and how to respond rapidly. So thanks for that, Brian. Um, can you tell us a little bit about the effect of COVID on the heart?
COVID, of course, is a terrible, terrible virus which affects basically every system in the body. I have a daughter who had long COVID and was fairly incapacitated for many months, and gradually is working. She's not nearly back to where she was, but she's active once again, but it took 2 years. It can affect the brain. You get the brain fog. It can give you all sorts of gastrointestinal trouble. And what we found was that it actually, the major problem was obviously lungs. You get the lungs filled with fluid from a horrific inflammatory reaction. And if you can't oxygenate the blood, the heart, if the heart doesn't do a great job pumping unoxygenated blood, there's relatively little. It potentially, they could find COVID viruses and stuff in heart muscle of people who died, but when you looked at their ultrasounds of their heart, the heart's still squeezed pretty well. The one thing that got a lot of press was that young men, after the second COVID injection, a few of them would have what we call myocarditis, an inflammation of the heart muscle, manifest on an EKG with some chest pain. It was usually very short in duration. There was no mortality with it, but they'd have chest pain and an abnormal EKG for 2 or 3 days. And the number of young men who got that was incredibly small. And again, it seems to be a transient phenomenon. Many, many more young men would have died from COVID than the ones who were protected from the COVID vaccine, even though they wound up getting the myocarditis. Let me give you an example. In, I think it was May of 2021, COVID was running wild in Italy and New York City and LA, and it was not here in the Pacific Northwest yet. At that time, in our 350-bed Asante Hospital, we had 7 COVID patients actively in the hospital because of COVID in May of 2021. Fast forward 4 months later to August of 2021, we had 184 sick COVID patients in the hospital out of our 350 beds. Okay, 20 of them were in 50 of them were in the intensive care unit, and 20 of the 50 were on ventilators. 95% of them were unvaccinated. That's an astounding number. At that week, we had the highest percentage of COVID people in the world. CBS was out here interviewing. It was a terrible, terrible disease. It can affect all organs. It tends, actually, the heart gets the least involved with it, but the lungs were the most impressive.
You had mentioned, somebody asked about the Pacific yew tree. You had mentioned the yew tree. Can you talk just a moment about that chemical? And you mentioned one shortly thereafter. I think you were showing Easter Island, but I'm not certain.
Yeah. So the Pacific Northwest yew tree has a chemical that's called Taxol, and it was purified and modified and was used to treat ovarian cancer. And we still, a lot of stents are covered with that. We've elected to use the one that is covered with a variation of sirolimus. Sirolimus is a chemical found in some bacteria, I think, in the dirt on mud piles of Easter Island, and they modified it to a medicine called everolimus so that they could stick it to the stent and it would leak off at just the right rate to prevent the healing process being overzealous. And it's just a phenomenal story because the restenosis rates drop dramatically. I mean, down to 3%.
Yeah, thanks. I'm looking for more questions in the chat if people have them. In the meantime, I think it would be worthwhile to spend a moment or two on the electrical devices that we can possess. Can you talk a little bit more about the role of the iWatch and the role of the
Yeah.
Cardia and similar monitoring devices?
Yeah. So the Cardia device, which I showed you, I don't know if you can see this.
Yes.
Just this little device there. I stick it to the back of my iPhone, so I always have it. But it's basically a free app, but you got to buy the little equipment, this little two silver squares there. That's about $88 or something on Amazon. And it is a bona fide FDA approved EKG. You basically put two fingers on it, one on each of these little markers there, and it creates an EKG of a lead one. Now, when we do an EKG, we get 12 leads, but in one lead, I can often diagnose what kind of heart rhythm they have. They have a modification of that with an extra lead on the back. If you put it on your knee and your two fingers, you can get at least 6 of the 12 leads. And so that is a bona fide true EKG. Now, when you wear an iWatch, it's constantly measuring your heart rate. It does that with what's called photoplethysmography. Every time your heart beats, blood goes into the capillaries, and it kind of has an algorithm that kind of analyzes, is it regular and is it in a normal heart rate range? And it says probably normal rhythm, but it's not a true EKG. And sometimes you can get a lot of skip beats, and it can fool a thing to thinking you're in this rhythm called atrial fib, when in fact you're just in a normal rhythm with premature single extra beats. But if you put your finger on the little spin dial, it then, with the proper activation of the program on the iWatch, gives you one lead on your left wrist, which is the photoplethysmography, but it makes a contact with the skin. And then the other finger on your right hand is touching the little spin dial. And now you have a lead one. And at least with the Apple Watch, that is a true EKG. One lead.
Fascinating. It's wonderful.
And my son was showing me one time when they want some of the earlier models of the iPhone came out, he would stand across the room, turn the camera on me, and he would tell me what my heart rate was. The phone, the camera was so sensitive, it could actually see the pulsation of the capillaries in my face, and it would pick that up, and it could translate it into a heart rate. And that's what the back of the watch does on your wrist.
Brian, we know Rogue Regional just had an expansion with the addition of the new pavilion that you mentioned. How many CCU beds and other cardiac units did we gain?
Well, we nearly doubled the cardiac care unit, which takes care of our bypass surgery and our heart attack patients. I think they're probably up to almost 30 beds or so there. I mean, I walked in there tonight. Holy mackerel, it's this long corridor with separate nursing. It's absolutely a beautiful ICU, CCU. Then there's another whole separate area, which is intensive care unit, which takes care of people who have, major infectious processes, sepsis and stuff like that. I think there's another 40 beds there. I mean, one of the reasons we expanded the hospital bed system is because, as the largest provider of care, you've got a lot of smaller hospitals around the area. They're good at taking care of simple pneumonias and doing their, standard surgeries of gallbladder and stuff. But when you've got somebody who's got major medical illnesses, they have to be at a place where you've got multiple specialists. You've got cardiologists, pulmonologists, kidney doctors, infectious disease doctors, intensivists, because these people do require round the care clock with really incredible amount of high technology stuff. Medical knowledge is doubling every couple of months now. And so you need that resource for the really, really sick people. If you're not really, really sick, having a local hospital to take care of you is what you want. It's just kind of closer to home, closer to family being there. Depends on the situation that you have.
All right. Here's another question from the chat. And I know this I think about this too, because I have friends or relatives who you hear about having heart troubles and getting a stent, and then 6 months or 6 years later, something happens and they go back and get another stent. How many stents can somebody have?
Well, yeah, that evolves as we've had originally bare metal stents. You had 15 out of 100. As it healed, it would come back. It doesn't take a whole lot of healing to block off a 2.5 millimeter vessel, but that's still 85 happy customers. Okay, first time around. Remember that stents don't cure heart disease. They take care of the kink garden hose at that spot. The aging of the artery, the aging of the patient still is occurring throughout the body and at other areas. So, there have been in my tenure here, 42 years, and doing stents for the last 25 or so, I've had maybe 3 people that I've had to put 3 stents at the same spot. Most of the time, it's just one. But it's not unusual. You got a blockage in the right coronary artery, had a heart attack. We open it up, put a stent. 5 years later, they have a blockage or a partial blockage in their left anterior descending. We put another stent, maybe 2 stents because it's a long area blockage. And 15 years later, the circumflex gives them a problem. So, the stenting procedure is sometimes even an outpatient procedure. Usually it's an overnight, but for a heart attack, it's a 2-day hospitalization. Open heart surgery is a phenomenal strategy. We've got great surgeons, but it's 5 days and 6, 7 days in the hospital and an open chest. For some of the surgery they do, we can do a mini thoracotomy. We don't have to open the whole chest, but it's a much bigger procedure. But there are certain kinds of vessels we simply can't open. There's too many curves or bends or too many blockages, in which case we want the cardiac surgeons there because they can revascularize a much larger number of vessels. But if I've got 1 or 2 blockages and they're approachable, give me a pinhole in the groin rather than a zipper on the chest.
All right. I will note that it's 8:03. Dr. Gross has graciously agreed to hang around as long as there are questions, but we certainly understand if you need to leave. Brian, you were boasting very appropriately about the successes of Rogue Regional and our entire health system in Southern Oregon and the awards won. How do we compare to other major medical centers on the West Coast?
Oh, I think, that last slide that I showed you with the comparing our heart center to the 951 major heart centers in the entire country, we were in the top 50. So,
Terrific.
the major ones on the West Coast, you've got a bunch in California, obviously, but you got Seattle, Tacoma, Olympia, Vancouver, Oregon, Eugene, Salem, and us.
All right. Got a couple of important questions here, and I think we'll finish with these because these are other large questions. The first one is with atrial fibrillation, and you can tell us if one of the other speakers will be speaking about this, but with atrial fibrillation, you talked about blood thinners and you mentioned ablations. Is one favored over the other? How do they work together?
Yeah. Well, a lot depends on what you have. If you happen to be a 30-year-old person who has atrial fibrillation and structurally you have a normal heart and you don't have any diabetes or any hypertension, you don't need blood thinners. Your risk of having a stroke is so small that the risk of being on a blood thinner exceeds that. So we don't put those people on. We try to control or prevent the atrial fibrillation with some risk factor modifications. We have medicines that can slow it or prevent it, and sometimes we'll even use antiarrhythmics. However, what we found is most people don't want to take an antiarrhythmic for the rest of their life. And so we would be very prone in a young person with atrial fib that is frequent and bothersome to ablate it with either the radio frequency, thermal burn or the cryoablation, liquid nitrogen, and highly successful in a young, healthy person. 85% of the people will be atrial fib free for decades. Now, the older you get and the more structural heart disease and the more other comorbidities like high blood pressure or diabetes or vascular disease, those people have a higher chance of having atrial fib and a higher chance of it coming back. And when you have atrial fib with a number of risk factors, you should be on a blood thinner because one of the major causes of stroke is when that top of the heart is quivering, it's not squeezing and emptying itself very well, and blood clots can form, and blood clots that form can fragment. And if a chunk of blood clot goes to the brain, then you've got a real emergency with a stroke. So we'll try various medicines. We sometimes we'll use ablation. We'll sometimes use medicines. It depends on how sick the patient is, how severely they're incapacitated. So it's, atrial fib, when you and I started practicing, was pretty easy. You put them on DIG, maybe quinidine, and that was it. And now there's so many different choices of blood clot dissolving medicines. Which ones do the insurance cover? Okay, which kind of antiarrhythmic therapy? Which kind of ablation do you want to do? It becomes a very complex discussion, but we deal. It's a very, very common office process for me. I'll see 3 of them a day for consultation when I'm here.
All right, thanks. I think I'll make this the last question, but it is a bit of a big topic. Tell us a little bit about the difference in presentation of heart disease between men and women.
Yeah, always a hot topic, especially around February 14th. I would tell you that the majority of the symptoms are very similar. Yeah, you often see the picture of the fella climbing the stairs who's about 60 years of age, gripping his chest, and it's sometimes going into the neck or the arm. And it doesn't have to be the gorilla on the chest. It often is, though. Those of many patients who have had a heart attack will tell you of an extreme discomfort. But many of them also have had milder discomfort, maybe just the elbow or just the jaw, and they were confused as to what was going on. Men get heart attacks about 5 to 10 years earlier than women. But as you get older, you tend to have more comorbidities, whether it be weight or arthritic problems. And so they're not as active. They don't necessarily get the early warning systems when they're walking up a hill or out jogging that they get chest discomfort. That they tend to have more fatigue and shortness of breath. But I would tell you the majority of them have a chest discomfort component that is similar to what men complain of, but they have a higher incidence of more atypical things of fatigue and shortness of breath. But, if somebody comes to your office, Steve, and they complain of fatigue, heart attack is not the first thing that I usually think of. Every medical condition that you and I deal with, fatigue is on that list. So it takes some sorting out and looking at a whole bunch of different things and examining them. And that's why, a very personalized evaluation is necessary, so you're not barking up the wrong tree.
I said that was the last question, but I've gotten this one a couple of times in the chat, and this is a quickie show and tell, I think. Can you show us on your phone which pulse point app people should be using?
Sure.
Apparently, people have tried to go online while you're talking, and there are multiple choices.
Yeah. It's the red one right there. And if I open that up, it's called Pulse Point. It basically, I have it tuned to tell me about where.
Back up just a little bit. Back it up just a little bit.
Okay.
There you go. Good.
It tells me I'm following several paramedic units around town and ambulances, and it tells me where the medical emergencies are and the traffics and the fires and all that stuff. So it's actually much more than just taking care of a heart attack. And then the yellow one basically shows where all of the AEDs are located. I'm the blue circle, and that's where all the AEDs are, and you can expand it. And so it's a novel little thing, and it's got a picture of where the AED is mounted in the office for each of those places, providing they didn't put it in the top drawer of the desk and nobody at the front desk knows where it's at.
All right. Well, thank you everyone for your attention. Thank you, Dr. Gross. Whether we're speaking here in front of 150 people or it's just you and I on the wards, it's always exciting and interesting to speak with you. Thanks very much.
It's always fun to connect with you, Stephen. Good luck. Okay.
Thank you.
Bye-bye.
And did you want to let us know what the next session is?
Yes, it's next Wednesday, same time, probably even same place on your Zoom, and that will be with Dr. Daniel Jacks. She's a cardiothoracic surgeon, and she's going to be talking about heart bypass surgery, also known as CABG or CABG. And, basically, why is it done? What is the procedure, and how people recover from it? And it's a very common procedure. I think we all know somebody that's had open heart surgery, or maybe we've had it ourselves. So I think it'll be an interesting talk. So thanks everybody for attending, and the recording will be provided to all the registrants probably at the end of all four lectures. We'll send something out to everyone with all four recordings. But as you can see, it's worth attending live because there will be the opportunity for Q&A, which you don't get if you're watching it as a video. So good night, everyone.